السلام عليكم جميعا. كل عام وأنتم صحة وسلامة. Good afternoon everyone. On behalf of the Continuous Medical Education Department at King Khalid Eye Specialist Hospital, we would like to welcome all of you today to our seminar titled Cornea and Ocular Surface Diseases Seminar. I'm sure it will be interesting to all of you. We are delighted to have you, Professor Sangwan, and thank you for accepting our invitation from Continuous Medical Education Department. We hope you enjoy your stay at Riyadh. This activity is accredited with 5 CME, and we would like to remind everyone to make sure that he enters his information, especially Saudi Commission for Health Specialty number, and don't forget to check out after attending this seminar. In order to obtain the CME, you need to attend the whole seminar and complete the evaluation form that will be sent to you, and make sure of the correct entry of the Saudi Commission for Health Specialty number. And please, you can do a scan the program of this seminar. We would like to thank all the members and fellows in the anterior segment division at King Khalid Eye Specialist Hospital and Eye Bank Department for their major contribution in the Visiting Professor Week. We would like also to thank the chairman of the anterior segment division, Dr. Mohammed, for his great effort, and I would like to ask him to introduce our visiting professor and to moderate the seminar, and thank you.
Good afternoon, everyone, and many thanks for coming. It gives me an immense pleasure to introduce Professor Sangwan, who has come all the way from India to teach and train us on limbal stem cell transplantation and ocular surface diseases. For those who don't know, he's world-renowned in ocular surface disease. After doing his initial training in India, he went to Massachusetts and did a 2-year fellowship with Prof. Steve Foster. After returning back, he developed the ocular surface program in LB Prasad Hospital, where he was instrumental, and he developed the stem cell lab there. And he ran that program very successfully and was able to perform more than 300 K-pros and over 3,000 limbal stem cell procedures. He is world-renowned and had developed multiple techniques, has been on the board of many international meetings, and has been a guest speaker all over the world. He doesn't want us to introduce him further, and I think his talks will explain everything. So please welcome Professor Sangwan.
Yeah, good afternoon, and thank you very much for having me. And Professor Ahad, thank you very much. And K-Cash, I was here in 2014, so this is my second visit. When we had a stem cell lab here, a cultivated limbal epithelial transplant, and 2014 I was here for 3-4 days. Today, I'm going to talk first about bioengineered cornea. What is the current status? This topic has been very close to my heart and for a long time. And now I'll say what we have been doing and what are the possibilities of availability of such a tissue. We know that there is a huge backlog of patients who need corneal transplant. For example, in India alone, 8.4 million people, corneal blind people, are waiting. And on an average, every year, we do about 45,000 keratoplasties all over India. The need is more than 200,000 every year. And globally, 1 in 70 patients who need a corneal transplant, only 1 patient gets the tissue. So also, those of us who are doing corneal transplant, we know the transplant survival and outcomes are poor, especially in patients who have ocular surface disease, high-risk grafts, and variety of other conditions. If you look at the corneal blindness holistically, the recipient factors, which are 60% bilateral cases, are high risk, and they are unfit for corneal transplant. There is a limited availability of corneal tissue, limited utility. Even when you harvest or retrieve cornea, only about 25 to 50%, 60% are usable. And social, economic, and logistical factor. I'm sure you will encounter here when you do a PK, if the patient lives very far off and cannot come when there is a rejection, you lose that graft. In India, we find this is very important problem. because you do the surgery, patient goes 1,000 miles away and he's not able to come. There is no cornea doctor who can take care. And then another issue is rejection and failure. This is a real. In 64% or 64% patient in the first 5 years will encounter rejection, or the survival will be that much. About 50% at 10 year. Keratoconus and dystrophies. These are the two indications where the survival may be very good, maybe 80-90%. Rest of all the indications are not that great. When we say biosynthetic or artificial, that means it's not made from human, or it's not derived from the human tissue. So there are varieties of ideas in development from very beginning. I think the best paper and the best work has been in 1919 by May Griffith. She made from cell lines the whole cornea. However, clinically did not work. Then there are people who we have worked on recombinant human collagen. I will show you that work. Then there are various type of capros. Some people call that also as an artificial cornea. Variety of scaffolds and cell therapies. And I'm currently also working with the Israeli startup to develop a new type of capro. The company's name is Cornea. In 2013, we got a grant from Government of India and Sweden, me and Professor Meg Griffith. And we used, our idea was to use recombinant human collagen 3 and develop a artificial cornea. So if you look at this is the device that was developed. This is the real work that we are doing in the lab, wet lab in our LVP. And this is the biosynthetic cornea made from the recombinant human collagen. And I'm just cutting this on an artificial anterior chamber. You can see this after partial cut. Here the anterior segment ASOCT shows the partial cut. So this was as a preparation to human corneal transplantation. And this is the a femoral LASIK being done to remove the corneal scar. You will see after the laser part is over. So this is a corneal scar in which we removed the scar part, dissect it with the femtolasic, and now I'll remove the cap with the scar, and then use the lamellar graft made out of recombinant human collagen. So what I am talking today is not in the lab or only theoretical. This is a real possibility, and this patient I had done in 2016. This is I'm trying to just debride the epithelium so that I'm going to put the amniotic membrane on top of this recombinant collagen cornea, because you cannot suture, that's not suturable. This is fibrin glue, which we are using here for variety of other things. And this is the cornea which was cut with the femtolasic, a corresponding part, and then I'll arrange it, fit into this defect, and then put a amniotic membrane. On top of that, I'll put a suture, overlay suture. Because this was the first case, I did 2 cases at that time. So there's no sutures. We did overlay sutures just to make sure that it doesn't get displaced. This is the amniotic membrane with the fibrin glue. And this is the overlay suture. And this overlay suture was removed after 1 week. And this is the post-op appearance. And if you follow it over a period of time, this is like I followed it for up to 4 years. These are the picture how it looks. From counting fingers, he improved the vision of 20-25, and that cornea remained clear as long as I had followed. After that, I moved from LVP, so I really don't know what happened. But I'll show you more other cases done by my collaborator in Sweden. So this is a multi-center study which we did. This was high-risk corneal graft in patients where there was corneal scar, there HSV, there are a variety of other infection scars due to this, or chemical burn, or SJS. And this study was done in Cardiff University, Ukraine, Philadelphia University, and Montreal, and LVP Hyderabad. And this was published in Regenerative Medicine in And this was one of the unique study that we had published. Prior to that, our collaborator in Sweden, Professor Per Fagerholm and his team uh, used this same recombinant human collagen in 10 keratoconus patient, and they have published 8-year results. Now it should be around 15, 18 years follow-up. So this is all published in Biomaterials, and you can see that these corneas are well maintained, no rejection, no epidefect, and you see the stable immune compatible regeneration of the nerves. You can see the epithelium, stroma, and nerves. 3 of the patient had to regrafted for variety of reasons, and in that you can see that excised cornea had presence of the collagen 3, which was put in, and also there was a collagen 1 and collagen 5 also, which means that it allows the endogenous regeneration by the stromal keratocyte, the new collagen, and the old one gets replaced over a period of time. The problem with this recombinant human collagen was, number one, it was very expensive. We didn't have IP, so there was a lot of other issues, logistical. So we moved out, and then we started working on a idea of liquid cornea. So liquid cornea is like the SLET we are doing for limbal stem cell deficiency. So liquid means it is a bioengineered cornea. It's in the liquid form, and it can take any shape you like in situ, and it gets polymerized in situ on the surface of the eye. So this one idea that I have been working with Professor May Griffith, this is collagen-like peptide, and this is purely synthesized in the lab, chemically synthesized, and this material is named as liquid cornea, and it is has undergone trial in the mini pigs, in rabbits, and it seems to be doing very well. And now we are writing a grant, multi-center grant globally to develop it further. The similar kind of work that I have been doing with Professor May Griffith, because that is an academic work, and this is I work with a company called Pandorum Technologies, a startup from Bangalore. Since it is funded by private venture capital, I feel that this work progresses much faster. So I'll show what that work is. So this liquid cornea has 3 components: a hyaluronic acid derivative, a photoinitiator, and a collagen, and exosomes which are derived from mesenchymal cells. So these all 3 components will, like fibrin glue, you have fibrinogen, thrombin, you have their solvents, you mix it and it polymerizes when you mix together. Similarly, this liquid cornea can be used as a gel, as a adhesive, as a space or mass filler, and exosome can act as a basically regeneration part and anti-inflammatory part. And you will need 5 to 10 microliter to fill the defect, or depending on the size. This is how the surgery we envision. I'll show you further details about this technique. So essentially, this will help address, even if you have a small tiny scar, which normally you will not address because it is in the center or paracentral area. So with this technique, you can scoop that out with the laser or with the trephine and fill that crater with the liquid preparation. And 1 minute of normal light, microscope light, is good enough for polymerization. You can also make into a sheet, like a lamellar keratoplasty. So this is very versatile material. And this is the liquid part, where schematically showing the remove the epithelium, debride the stroma of the scar, and then fill it and allow for a minute to polymerize. And also you can do 3D printing of the same material into a collagen cornea. And these are the rabbit experiment, where we have done multiple series of experiments here, like what you are showing. If the liquid cornea preparation along with the bone marrow derived exosomes, the complete epithelialization in 14 days. If you use only the polymer, it takes longer time. If you don't use anything, or you use a clinical grade sealant like cyanoacrylate, then you know how it works. Again, just to show you the surgical technique that which we think that would work, and this is done in the rabbits. There is a animal facility near our hospital where we work, and this is called Dauber Research Foundation. So this is how you put the liquid preparation, and once you polymerize, put a BCL. So your surgical part is over. This lab which we have in animal facility is equipped with all the imaging studies for the cornea, including ASOCT, slit lamp photograph, pentacam, and densitometry. So all these outputs are read for all the animals, and the data is then analyzed. These are, pachymetry and slit lamp assessment with or without fluorescein, the volumetric analysis. So I'll give you one example of this rabbit 44, followed how meticulously this is followed and treated over a period of time. You can see up to 60 days, 2 months we follow. And then they also undergo extensive imaging studies so that we can understand what is happening at the tissue level. So the name this Pandorum company has given Curagenics, which is a only the hydrogel material. There is no exosomes. So this can do variety of things. There are many clinical applications we think with this. And this is the clinical photograph of the rabbit study. Then in last year and a half, there have been key regulatory achievements that the company has achieved with FDA, that they have been able to get a orphan drug status for this Curagenics and for this liquid cornea. And now the FDA has advised them to do a first in human study, which is now we need to manufacture exosomes. We need to manufacture the Curagenics in a very high quality facility. So all that process is going on. And this pre-IND submission has already happened. And in India also, this same process is being followed to submit the material and data to DCGI. We have our own patents. So it is entirely whole procedure, everything developed in India. It's a IP protected, a good amount of publication, good amount of funding. And recently, in last year, late last year, this work was covered in Nature Biopharma journal. And this is the plan that we have Curagel and KXO. We have a clinical center in US, Northwestern University, Chicago, ourselves in Delhi, and then Professor Kinasota in Japan. So we are going to do different studies in different centers. And this is a composite picture of this Curagenics. Curagenics is with the exosomes. So you can see the densitometry, pachymetry, the clinical images, and histopathology. And these are the pictures, histopathological pictures. If you look at the human cornea, the rabbit cornea normal, the first two picture, and third picture is the neurotrophic keratitis without any treatment. And the fourth picture is 90-day post treatment, Curagenics treatment. So you are able to achieve the histology which is near normal. This is the pipeline, or this is the timelines. We think that we should be able to start the trial somewhere in the first quarter of next year. And in 2026, we should be able to do the phase 1 and phase 2A trial, and hopefully it should be licensed and commercialized by 2026 second half or early 2027. So if everything works okay, I think the liquid cornea or the bioengineered cornea is around the corner. It's no longer only a myth or in the lab. This company is quite well placed in terms of their funding and their patents. These are both founders. They are from India. These are the below is the advisors and scientists. These two doctors are from Northwestern, Dr. Ramiz Hadedin and Satish Nadeg. And these are investors. They have already raised about $20 million US dollar from different venture capital firms, and they are looking for another $15 million now. And the cornea is their flagship product, but they have some other products as well, which they are developing. Last year, we also got a grant from DRDO, which is the Defense Department from Government of India, to develop a full thickness corneal bioengineered cornea. And our goal is to develop a bioengineered cornea which is full thickness, because this one is a partial thickness. So we are developing full thickness, and the material is being developed by scientists from DRDO. The lab work and animal work is being done at our lab. And this is one of the such material which is suturable, because we think that full thickness you need to suture, otherwise it may not stay. So it's very early, but we are developing and we are moving forward. So we are working on bioengineered artificial cornea, full range. So in summary, it is very much real, and we are hoping to apply DCGI FDA approval. This process is already started. We also applied a grant for the liquid cornea from Government of India, and this DRDO grant, which I just told. So it is, once it is developed, I think it will make the surgery, corneal surgery, much simpler, like SLET, what we think that we can move away from the lab, and the cost also, it will be much simpler, much easier than what we are encountering currently. Thank you very much. Yes. If there is any questions, comments, or
Thanks
any
a lot.
clarification.
Yes, thanks a lot for excellent talk, and I think we are all looking forward for these sort of bioengineered cornea. Any question from the floor? Dr. Kirat, you are always skeptic about these sort of things. So, which cells are you used to get these exosomes from?
We have tried different, but most recently the keratinocyte stem cells derived from the limbus.
From the limbus, so like a dead donor.
Yeah, from the cadaveric. But now we have moved away from that also, because then it means you will depend on the cornea,
yes,
or the limbus. So now it's bone marrow derived.
That's what I'm going to say.
With conditioned media.
Okay.
And these are being produced in a very clean environment somewhere in US. It's going to cost a lot, millions of dollars to produce those exosomes. But those exosomes are such that you can fine tune the cargo. You can fine tune what factors you want, what factors you don't want, so that it enhances the corneal regeneration. And also these exosomes can be used as eye drops. The pharmaceutical will also be developed around that.
Okay.
At the moment, it is focused on the cornea.
So based on the rabbit studies, I mean, the couple of things which we all see if we are using these sort of sterile corneas. One thing is the epithelialization, which usually takes a bit longer than the normal cornea, and secondly, the risk of necrosis and melt of this sort of a tissue.
So for here, because we have rabbits several rounds for 90 days, 6 months, and we've done the histology, we have done the immunohistochemistry, all those things. You don't encounter those things.
Okay.
So, like for example, now we are developing the material for full thickness. So first thing that we want, suturability. Second, we want the all characteristics of the cornea, desirable cornea. Third, it should be able to support the epithelial cell growth.
Okay.
So we do those study in the lab, and then only the material go further.
Okay. Coming back to the same thing. So because it's in a liquid form, so obviously you cannot suture it, and when it's polymerized, it sutures. So what is the integrity and strength in the future once it is there? Like say it has been stabilized now, it should be strong enough as a cornea.
Yes, of course. So these physical characteristics are also tested beforehand when you decide the material. For the liquid, these material is those characteristics are not required, because you are not replacing the whole cornea. You are only doing a patchwork.
Okay.
You're removing the scar, putting it. Now, when you develop a partial thickness cornea, again, the tensile strength is not important, because your majority of your cornea will be recipient, and then you're just replacing the scarred part. So full thickness cornea, when we are developing, all these characteristics will matter there.
Okay, so currently you are not focusing on DALK or sort of a procedure.
No, this will be for DALK also. This will
Because
be
for DALK you need that sort of a tensile strength and everything.
yeah. So that will be when we because see right now the company and the investor are focused on bringing one indication to commercial so that proof of concept, and then all these other things will develop. Like Professor Kinosita is focused on developing this material for OCP and Steven Johnson for the treatment. So we in RO we recently had we had a meeting, and we both got a Indo-Japanese grant also for next 3 years to develop to work on these ideas.
Great, thank you. Any questions?
Thank you very much for your nice talk. What factors keep the clarity of the artificial cornea?
What factors keep the clarity
of the cornea?
Because the collagen or the material that what you are using is transparent, and that is the knowledge or patent what you have, that how do you mix say certain collagen, hyaluronic acid, and the cross linker. So that is the art part of it, and the exact mechanism and all that the company would know better than I know. But for me, as long as it's transparent, I'm very happy. And the one which we did, recombinant collagen, now it's more than 15 years in human eye, so there are no reason for us to worry that it will not remain transparent. Yes, sir.
Thank you again. Two questions. Maybe you have alluded to before, but I came late. Now, how does it respond to trauma or to any insult in terms of a healing response, and how does it maintain avascularity as a normal cornea?
Avascularity is because of the structure, and with the liquid cornea, you can tune. You can in your exosomes, you can incorporate HGF, hepatocyte growth factor, which is or you can use more of S flat, which is anti-VEGF factors. But whether how they deal with the future trauma and all that, only limited knowledge we have of recombinant collagen, and on those patients we did not encounter. But if there is a problem, like 3 patients of Dr. Prof home, we need to retransplant it, so they underwent the resurgery. So all those things will come only when we start doing human work. At this moment, that is not known.
Any further question?
Thank you.
Thank you, Professor. Thank you, Professor Sangwan. That was very interesting lecture. Now we are going to move to the other talk. It will be transplant-ready endo-endemic. It will be presented by Dr. Mohammed Ahad. And Dr. Mohammed Ahad is the chair of anterior segment division at King Khalid Eye Specialist Hospital.
So thanks a lot again. Basically the talks are for Prof Sangwan, and me and Dr. AlMutlak are sort of filling in so that he doesn't feel that he's just running all the show. So we'll give a bit of a rest to him between his 3 talks. So I'm going to be talking about endo-in corneal transplant, just give a brief summary and our recent experience, and Dr. AlMutlak will be talking about high-risk corneal transplant. So as the name says, transplant-ready endo-in DMAC. So the focus is basically endo-in DMAC, the way it is sort of put it into the tubing before we start. Special thanks to Lions World Visual Institute, their medical directors and their research developers, Dr. Ben Bright and Dr. Eric Abdullayev, and our faculty and our iBank staff and our fellows. So corneal transplant has been around for more than 100 years, even more than that. So 115 years. And for 100 years, the standard procedure was just PKP. And we were just thinking of how we can improve the suturing technique, which sutures can be used. Shall we use a round refine, or it should be square? And then for all sort of cases, for epithelium, endothelium, and stroma, we were just using a standard full thickness. And then suddenly, at the beginning of the 21st century, things change and someone starts to thinking out of the box and it goes to Garrett Mellis. And then you suddenly start to have a DLAC procedure, which he initially called. Then they changed the word to DSAC. Then DMAC came, and then PDAC came. And this is how, once you start thinking out of the box, things become like they explode. And it's not going to stop there. I mean, for sure, it's not stopping at all. And the future is the culture endothelial cells. And thanks to Professor Kinoshita, I mean, who have done a lot of good work on that. Now he has sold his IP to this company, Orion Biotech, which has developed this commercial Visnova eye drops. And now they have done more than 130 cases of these cell therapy. So cell therapy is future. Visnova is there. M-Cell is using nanoparticles. So basically what you do, you inject these cells. So you scrape the endothelium, you inject the cells, and then you ask the patient to lie face down for 3 hours. But if you're using M cells, they have got nanoparticles with magnet in it. So and then you put a magnetic contact lens. So patient doesn't even need to lie face down. And now the human trials have started in US and Europe. So why it is important, why cell therapy is important, or why anything is important? And this is because any intervention that needs to be successful should have better and predictable outcome. This is first thing. And secondly, it has to be user-friendly, so ordinary surgeons like me can do it, anyone can do it. I mean, there's no point of inventing or starting a very complex procedure which only few people in the world can do it, and most of the world cannot get benefit. And this graph explains very nicely. So when the DSEC came in 2005, it was a relatively sort of a straightforward procedure. So look, it jumped in a couple of years. They were doing good number of cases. Compared to DMAC, when the DMAC came, it was very difficult to peel the thing. Once the eye banking started to peel the things, that it became a bit easier. And in 2017, when the preloaded, pre-stamped DMAC came in, it took over. So very important for the technique to be simple, straightforward, user-friendly, so that everybody can use it. And why DMAC is important for Middle East, and this is I keep telling all the time, because of two reasons. One is the pathology and one is the tissue travel. Most of the time, well, 99% of our cases, we import the tissue from US, and we know very well that for 4 sort of days, if the tissue is pre-cut or pre-loaded, it works very nicely, and studies have been done in Japan and in overseas. And we have shown it recently. I mean, we are writing it up, and we showed that DMAC survives far better than DSEC if it is pre-cut or preloaded. And we have done cases of preloaded DMAC where it has been preloaded for 8 days and it survives. But if there's a preloaded or pre-cut DSEC, it does not survive. And the other thing is pathology. In the West, we all talk about Fuchs, because this is what they have got. And we all know very well whether you do DSAC, DMAC, PKP, if it is Fuchs, it's going to survive. But what we have here is bullous keratopathy. So no matter what you do PKP, you do DSAC, it does not survive. And this is my personal data from UK. 60 cases of Fuchs dystrophy, 2-year survival, 100%. Comes to bullous keratopathy, I mean, the survival decreases 92%. If you have a previous strab, 71%. If you have tube, 40%. And these are all the papers from the West showing that if you have prior glaucoma, if you have got a bullous keratopathy, the survival is not as great as it is if it is a Fuchs or if it is a straightforward bullous keratopathy. And this is a very excellent paper from Donald Tan group, which shows that for Fuchs endothelial dystrophy, whether you do DMAC or DSAC, the results are more or less the same, above 90%, 96.2 for DSAC and 98 for DMAC. But when it comes to bullous keratopathy, the success rate for DMAC is 94%, but for DSAC, 65%, which means DSAC does not work as good as DMAC in bullous keratopathy, but in Fuchs, they both work nicely. And we're going to be presenting this data from our study here in Vancouver next month, where we showed that DMAC is 3 times better than DSAC in terms of primary and long-term failure in bullous keratopathy. And this is the irony. Like the complex cases where which we see in Middle East with tubes and with scars, they deserve DMAC. But DMAC is difficult to master. So we need a way to make this surgery easier. And this is where the Lions Eye Institute came up with this idea of transplant-ready endo in DMEC. It was launched last year in November, but we were lucky, and thanks to our eye bank and our team here, that we were able to do it before it was launched internationally. So we were the first one which we did outside the clinical trial in the world. So this is the traditional sort of a DMEC which comes in a preloaded way. Endothelium is outside, so it may be touching or it may not be touching the wall of the glass. If you are lucky, you will get a double scroll. If you are unlucky, you'll get a single scroll. And then when you go inside the eye, then the typical DMEC dance can take 5 minutes to 15 minutes, depending upon how tight is the tissue. But this is how endo in DMEC is. So it is folded against its will with endothelium side in, and the descemer membrane is outside. So one advantage is that it snugs very nicely inside the tube. It is not moving because it wants to open. But even if it wants to open, the endothelium is inside. So it's very safe. So not only it is safe, it is secure. And once it goes inside, it will open towards like a desect tissue towards, and because it wants to go outside again and sort of a endothelium out. So you want to lock it at that way. So it's opening and you want to lock it there and then you inject air. So this is the patent technique which they have developed, how it is folded. And they've shown that the average loss is about 4%, which we don't see. We see very late when obviously we see the veins. So basically it's a very inflamed cornea. So if you're putting a DSEC, which has got 100 or 50 microns of stroma attached to it, then there is always a rejection. And we always forget, and we also always thought that the DSEC does not reject. But they are talking about DSEC in Fuchs, where the risk is 1% or 5%. But DSEC in bullous keratopathy, the rejection rate, I mean, Donald Tan paper, they had 300 more eyes. And most of the cases that fail are basically rejection and then fail. And particularly it's an inflamed eye. And if you have a tube or trap, the aqueous barrier is broken. So they don't have that privilege. So that's why DMEC works better. And then it is quicker as well. So, yeah.
Thank you, Dr. Ahad. It's always great to learn from you, as usual. My question is, if you injected the DMEC tissue, and let's say that the tissue was ejected out, could you load it again or not?
No, so this way of loading is proprietary. They have got their own technique, which they're not gonna tell anyone yet.
All right.
So if it comes out, then you have to use your standard injector, put it in whatever cannula you have got it yourself. Yeah. If you find the tissue, there are nice videos showing there are no tissue there. Yeah.
This takes me to my next comment. I was trained to do endoglide DMEC. Prof. Jod, and Prof. Jod always does endoglide DMEC in very, very difficult cases, vitrectomized eyes, aphakic, tough cases. The good thing about the endoglide DMEC that you will trifold the tissue yourself, and then you will hold it with the forceps, and then you pull it in again. So the tissue is completely under your control, especially if you're trained well and you started with good cases. And whenever the tissue was ejected out, or let's say that you lost your orientation, I think you can reload it again and again. And the results of this technique are extremely good. Maybe that's the only thing that I can think as an advantage, a disadvantage compared to this.
I totally agree. George Mate has been doing this sort of a hybrid technique for many years now. And whenever we talk to him, he explains that it works very nice. The way they are advertising it, they say it's a non-touch technique. So because here it is a pull-through technique. You are pulling the tissue inside and then you open. So you're touching the endothelium. And obviously if it comes out, then the advantage is you can fold it again and do it. But this technique is no touch technique. So you're not touching the endothelium at all.
Yeah. Also, the Jodh Mehta's technique will be very difficult to master. You need to do a lot of cases. This technique is any novice, to my understanding, anybody who has done DSEC and understand how DMEC is done probably will pick up faster.
Right. Yes. If I can do it, anybody can do it.
Okay. And then I mean, you're a good surgeon. Allow me to comment on this. So actually, when you think about it, We here in Saudi, we learned how to do pull-through DSEC. This is our standard technique, and it differs between a surgeon and another. And if you want to find a way, the great idea in fellowship training is if you want to find a way to teach the fellows, you have to standardize the technique. And technically, endoglide DMIC is very standardized. There is like you can even count the steps that you want to do it from preparing the tissue itself to loading the tissue inside the eye. So from my point, my humble point of view, that standardizing DMIC starts from endoglide DMIC. That's the thing. But the issue with this technique, you cannot standardize it. If the case is very difficult and you lost control, then you're stuck with the tissue. You have to.
No, I agree. So tan endoglide, this is where I learned my DSAC with the tan endoglide, and this is probably, I still believe this is the perfect system. And obviously they use the same system to develop their endoglide for DMAC. And standardization is probably most important. Here, yeah, the point is once you lose it, then obviously you go back to a standard DMAC. So, but the good here is, I mean, so we are not comparing it technically with a hybrid or pull-through DMAC. We are comparing it with a standard DMAC. So it is far more standardized. There is no single scroll, double scroll. There is no DMAC tissue going inverted, no DMAC tissue going floating out. So what we are doing, we are comparing it with a standard DMAC, and we can compare it with the Jod Mehta DMAC because we say it is a non-touch technique. But I totally agree. A 10 endoglide system is very straightforward, and pull-through technique is very standardized. But again, when you go back to India, I mean, Susan Jacob and Amar Agarwal, the PDAC, I think PDAC is best of the both worlds. Is enough tissue for it to unfold and hold, and the thin is so thin that it gives you as good as any DMAC surgery.
Yeah, even for the audience not to misunderstand me, you need to learn how to do tapping technique definitely, because sometimes you lose.
I said
the
that
control once you lose.
Yeah.
So once
even you're doing a pull through, even you're doing endo in DMAC, you still need to know your DMAC.
Yeah. But I mean, it's a great way to start and then do both as an hybrid.
Because here you have only like a minute or 30, 45 seconds if your AC is deep. Otherwise, you'll end up having a standard DMAC. So you need to learn all the techniques. This is the same thing when phaco started. They say you have to learn ECCE to do phaco because you have to convert. But now how many surgeons are now learning ECCE in the West? Not many. Yes. So a time will come when it is so standardized and when so easy to fold that people will forget about tapping. A time will come. Actually, the time is coming very soon. It will be, we're not going talking about DMAC at all. It will be cell cultures. Like next year, it's coming in US, and in Japan, it is already approved, commercially approved. So I think 5 years down, we'll are talking about how to inject the cells in the eye.
Thank you so much.
There is another technique developed by Israeli company. I forgot the name, and they don't use any endothelium. It's simply like a contact lens, very thin, made up of material which is not biodegradable, and you do like DMAC. So you just put the
endo art.
So, and that seems to be working. So, and I no, listen now. I'm working with the idea that full bioengineered cornea, I don't think endothelium is required. So my idea is that if I develop fully bioengineered cornea, and the collagen and the structure is such that it's not hydroscopic, it doesn't get water. So why would you need endothelium? So the things will change with time, and I find that endo art technique quite good. I haven't done an LVP. We started the trial, and only problem with that is the failure rate is about 20%. So you may not need endothelium. You just against the IOP, it just closes the.
I think you still need the endothelium from the periphery because you need some degree of nutrients going from the aqueous. And I was in Paris last month in Cornea, and he presented his 5 years data, which a success rate of about 78, 80% as we are talking about. Yeah. But I think we are all skeptical about that, like how it's going to work in the long term. I think for the sake...
Thank you all for this nice talk. The idea of a structure that was created by God is not needed. This is absolutely not acceptable anyway. I don't think that at any time we can, make something that we don't need. For example, the endothelium. We don't need this. We don't need that. Thinking that we can make things that are better than what God created. These are still all trials, and time will tell. It's good for something to fill a defect. For example, if you have some liquid that can fill a gap in the cornea and then polymerizes. But what happens in the future, what happens over the years, we don't know. Now, thinking of a full thickness graft that replaces the central part of the cornea, we don't know how strong this thing is going to attach to the eye. How will it interact with the inside of the eye? And if you do it to a patient, for example, most of our patients here are young. If you do it to a patient, you expect the whatever you place in the eye to last for years and years. So I have some serious concerns about these, but time will tell.
Time will tell. Time will tell. I mean, we have K-Pro going on for 20, 30 years now.
Yeah, but unless we do and start having the experience, you cannot come to know. And the problem that we face in our countries, we need to find solution ourselves, not depend on Western countries. That's my personal belief, and I'll share my talk in the next talk about the corneal regeneration.
One more question: if this is an investment, for example, this artificial cornea and liquid cornea, what will the price be? Because we know the price of this material that you use for neurotrophic cornea. It's more expensive than the whole human. So what will the price, do you think, of this liquid cornea compared to the price
I don't know.
Of the cornea?
See, I don't know what it would be, but surely it will, in the beginning, it will be costly because the company and the investor need to recover their investment. So it would not going to be very cheap, but eventually I feel that if it works and if it is successful, the prices will come down. But in the beginning, it will be costly, and they will recover money in economies which are rich and where they can afford. So that part will be very commercial. At the moment, our focus is not on pricing. Our focus is on making it whether it works or not, and whether this we can produce a proof of concept.
Great. Thank you.
All right. So we'll briefly talk about corneal regeneration. And I started this work in 99 2000, and I'll share what we have done and where we have reached. This is a patient that I saw 2001, and this was just like 2 years after I joined LVP. This gentleman had a acid burn. He went to pick up his son, who was doing MSc chemistry, and he comes from Gujarat. So while closing the experiment, something went wrong, and father got the worst part of the burn. And all of you can make out that almost every doctor told them that nothing can be done, and he has to be in this state for the rest of life. The left eye was auto eviscerated. The right eye was, there was some sense, there was some cornea and PL positive, and therefore he came to LVP, and we started with a series of surgeries with the skin transplant, followed by limbal allograft from two of its direct limbal allo transplant with immunosuppression, followed with PK and ECCIOL, and we could restore 20 hundreds and N6 vision, which lasted him for 10-12 years, and then this graft failed. Then we did a Boston type 1 K-Pro, which lasted another 10 years. So, if you can extend the life by providing useful vision, it's very helpful. Another patient, again from Gujarat, had LASIK done in 2006. He works in London. So after LASIK, he went there, started working. About 12 days post-surgery, he developed fulminant fungal infection. And he was advised there to remove the LASIK flap, and then they gave up, and they said this eye is not going to be saved, very difficult. He came back to Ahmedabad, and from there he came to LVP. At that time, we started doing cultivated limbal epithelial transplantation, and this gentleman underwent a large therapeutic PK followed by autologous cultivated limbal epithelial transplant, and followed by another PK and with ECCIOL, and we were able to restore a vision of 20/50. So see, these things may look on the surface in the acute stage that nothing can be done, but if you step back and start thinking about or start doing something about it, you can find a solution. This is the story of a patient who had severe VKC, Abhishek Sharma. He was about to be admitted in a school for blind in 2000, and then in 2001 he came to LVP just to try if there is something possible. By then we had started growing the stem cells. So we took the tissue from the mother, grew it in the lab for 2 weeks, and then transplanted in both eyes. And he underwent he used the immunosuppression.
A year ago, Abhishek Sharma was almost completely blind from a degenerative corneal disease found mostly in the tropics.
Look down. Look up.
Surgeon Virender Sangwan decided the last hope was a stem cell transplant.
You said you're doing really well.
3 months later, Dr. Sangwan says the grafted stem cells taken from Sharma's parents to lessen the chance of rejection seem to be working.
Is he out of the woods, doctor? It's not really out of the woods, but we have to be on watch, and he has to be on a treatment, I said, to prevent the rejection.
No, Dr. Sangwan is really God for me. He make me able to see, and I can see, and I can read, I can drive my bike, and come back to my.
So now he has a twin daughter. He has his own business, and his stem cell graft is still working 23 years later. So we understand that the corneal, cornea is composed of 3 layers: the endothelium, stroma, and epithelium. And this is the part which is exposed to the environment, so most susceptible to trauma, infection, injuries, and then anything happens to it, scarring. And scarring leads to blindness. So what we have done in last 20-25 years from different part of the world, there are people who are working on different techniques. The epithelial regeneration we have been doing from 2001, and stromal keratocyte regeneration, Professor Fundenberg from Pittsburgh has worked extensively, and we have translated that work into clinical utility. Endothelial cultures, Professor Kinosita, and just now we heard, now it is possible to inject or develop a sheet. There's cell-based therapy. This is example of epithelial regeneration of this 6-year-old female child with the chemical injury. She underwent a simple limbal epithelial transplant, and this is how it looks like after 1 year. This is the before and after picture of her eye. Stromal regeneration, in the keratocytes, depending on the kind of injury, the hormone, the cytokine environment, they can tilt into a pathology or a physiological regeneration. So Professor Fundenberg work demonstrated that if we are able to provide the environment properly, they may start growing and create a transparent cornea. And similar work is replicated by Professor Sunil Chauhan at Harvard. Now I give you another example of a patient who underwent a simple limbal epithelial transplant in 2011, and this is after about 2 months later. This is 6 to 8 months later, and there is a scarring. You can make out there is a scarring, but every year when you see it, the scarring is reducing. Finally, he develops 20/40 vision, and most of the anterior stromal scarring is reduced significantly. Why is that happening? My theory is that in these limbal explants, there are mesenchymal stem cells, and those mesenchymal stem cells continue to work and remove that scar or remodel the scar. And we have shown that in the lab way back in 2006, 2007, when we are growing the cells in the lab, there are stromal keratocytes or mesenchymal cells. So now this part of the stem cell based therapy is very well developed, and in India, in LVP, they got the approval for human trial. This is a patient that I treated in LVP, bilateral toxic keratitis, and mesenchymal stem cells which are cultured mixed with the fibrin glue amniotic membrane could restore the transparency of the cornea. So where this stem cell therapy may be useful, I feel that patients with VKC, patients with chemical burns, patients with the Murans ulcer, the variety of technique, variety of indications where you may be able to remove the chemical and replace it with the mesenchymal cells along with the amniotic membrane, or maybe the liquid cornea. So, for example, you have the peripheral ulceration, you remove the inflamed tissue, and then you fill the crater with the liquid cornea, mix with the mesenchymal cells, or you exosomes, and you are done with the treatment, and it will biointegrate. So these are the potential application of mesenchymal stem cells or exosome derived from the mesenchymal cells. I will not talk about the endothelial culture because that's work very well published in the literature and now near clinical translation. So ocular surface, if we need to understand, there is three elements which are essential for the normal functioning: the preocular tear film, surface epithelia, and the ocular surface sensitivity. And for epithelial regeneration or epithelial transplantation to work, you need to have some minimal amount of preocular tear film and ocular surface sensitivity. Otherwise, the procedure won't work.
Our body is made up of cells: muscle, heart, skin. But most individual cells are short-lived, lasting only a few days or weeks. The job of stem cells is to divide and differentiate into these different tissues, replacing the old cells as they die off. They form the stem that produces all the cells the body needs. Stem cells keep renewing themselves. They provide us with a constant flow of new cells every day.
So all the adult organs or the organs have the adult stem cells, be it skin, hair follicles, nails, kidney, liver, all kinds of epithelia. So in the cornea, these stem cells are located at the limbus, and here what you are seeing is the damage of the stem cells and resulting in a condition called limbal stem cell deficiency. And the simple characteristics of that is conjunctiva grows onto the cornea. Since it's not normal for the conjunctival epithelium to sit on the cornea, it keeps breaking down, causes inflammation or light sensitivity and loss of vision. So what we have developed, the technique of LVP, in 2001, we started growing the cells in the stem cell lab. This is how we take the limbal biopsy, and we never used any genogenic material, or like no use of 3T3 fibroblast or fetal calf serum, autologous serum to grow the cells on a de-epithelialized amniotic membrane, grow for 2 weeks, and then use it. And this our protocol has been published in Nature Protocols in 2010. This is how you do the surgery. This part is similar what we are doing SLET. So here the penis dissection is done from center to the periphery, from periphery to the center, layer by layer, very, and this is the seat. This is very early videos that I used to suture the amniotic membrane with the cultivated epithelial stem cells. So it's very important that this dissection is done carefully, and we don't want to remove the normal corneal fibers. And this is what you can expect post-surgery. So this girl is from Bangladesh. She underwent the cultivated limbal epithelial transplant. The vision did not improve, so therefore we did a corneal transplant, and then you could see the histology of that cornea, and she recovered good vision. We have done, we reported 750 eyes of patient who had undergone cultivated limbal epithelial transplant with almost 76% survival at 1 year, and which falls to 64% in 3 years. And this is one of the longest surviving autologous clot followed by PK, and this girl lives in Dubai now. This is the Kaplan-Meier survival analysis of 526 eyes of autoclat. And these are some of the risk factors for failure. High risk factors: a pediatric eye, patient who had undergone previous ocular surface surgery or symblepharon release or clot with PK. So they may reduce the chance of success. And then we came, started realizing that clot is not very replicable technique. It is quite expensive to grow the cells. Only few centers or some centers who have lab can afford this technique, and the patient has to come twice, once to give the biopsy, second time to receive the transplant. And also we observed in pediatric patient the success rate was only 40%. So therefore we developed a technique called SLET.
Well, my mission is basically to learn about the science and technology of a new type of corneal limbal cell transplantation that Dr. Virender Sangwan has invented and popularized.
So this is a simple technique which we have done 2 cases today. One patient we did yesterday, and I'll talk about this. How did we develop? This is in collaboration with a professor in Sheffield. We started working on the idea of artificial amniotic membrane.
Using a synthetic scaffold will be more ideal because there's not going to be so much variation. It's going to be more predictable, and it's easy to synthesize.
It's made out of polylactic acid and polyglycolic acid. This is the material that we currently use in dissolvable sutures. So the body handles this very well. And we've designed the membrane so that within 2 or 3 weeks, they will just fade away, leaving the cells sat on the eye. So for this project, the 2 main techniques that we use to make the membrane is a technique called electrospinning.
A voltage is applied to the needle, and as the polymer solution is pushed out of the needle, the polymer solution is charged. This charged solution is attracted to a surface that is either of the opposite charge or earthed, and that ends up being this rotating collector here. What I've done is I've wrapped this collector with baking paper so that it's very easy for me to pull the scaffold off the surface, and I can actually culture cells onto it after.
Now we also have some fancy technology called microfabrication, where you can take polymers and make very small pockets within them. So we're also going to make an outer ring that will sit around the eye that will contain little pockets like limbal stem cell niches. And these I'm likening to a sort of unfurnished flat, that the limbal stem cells will go into these niches, make their own, and then use these as little hidey holes or caves from which they will then divide and send daughter cells out of the cave over the membrane over the front of the eye.
So when Professor McNeil talked about, when we are talking about artificial amniotic membrane, she talked about these micro pockets. So from there I got the idea, oh, you can grow the cells on the surface of the eye. You don't need a lab. And that is where we devised this technique of doing SLET and growing the stem cell on the surface of the eye. And this is the technique in brief. This is a very severe pannus, fibrovascular pannus. So you start dissecting from the periphery. You may want to put some drops like phenylephrine or bromonidine or alphagan, and then you, after cleaning up, do a little bit of cautery, and then you bring the membrane, stick it with the fibrin glue, and this is the biopsy which you have harvested from the normal healthy eye of the same patient, and then cut into pieces, and then arrange those pieces all around the cornea, equidistant, and then put fibrin glue on each of the explants, and then they hold the explants in place and put a bandage contact lens, and that is the end of the surgery. This is the what you can expect. This is a patient 6 weeks post-op. This on your left side is the total stem cell deficiency following chemical burn, and this is after SLET. This is a patient 1 year follow-up before and after. This is 2 year before and after. This is 3 year. So you can see the stability is maintained, and now you have patient up to 12-year follow-up before and after. The corneal clarity is maintained, the vision is maintained, and in some patient you can see the restoration of the pigmentation in the limbal area. Another patient with 12-year follow-up, and this is the confocal microscopy of the normal eye versus the transplanted eye or regenerated epithelium. So over a period of time, there is a basal nerve plexus gets formed. Then there are, since it is not patented or any nobody owns this technique, there are surgeons who are developing new and newer ways of using the technique. Some people have started using it for a sandwich technique, mini slat, or donut slat, or top up slat in excision of the OSSN. So variety of different people have started using and reporting it. This is the patient which I showed you. And this is the example of primary OSSN. When the OSSN is more than say 2 to 3 clock hours, when you excise it, there's very high chance there will be a stem cell deficiency if you don't do the slat. And so I taught Dr. Kalki, who's an oncologist at LVP, and now she has published a large series of slat in primary OSSN excision. This is a pediatric chemical burn, a 2-year-old child who had acute chemical burn due to bathroom cleaner, and underwent a slat in the acute stage with excellent outcome. So in patients with pediatric LSCD, we are doing slat in the acute stage. And this is the paper in ophthalmology we published in 2016, wherein we shown that the success rate of slat in adults and pediatric eyes are similar and very, very much better than what we were getting with the clat. And this is histology and immunohistochemistry of the excised pannus, post-slat, and corneas, and normal corneas. So you are able to restore the normal corneal epithelial structure and function. And this is the replication of our results by other groups. This is a multi-center study. This is a study from Dr. Mittal in Ambala, and this is a multi-central study from different cities in India and 3 different countries: Boston, Mexico City, Miami, and 4 cities in India. And they could replicate the results, and none of them were directly trained by me. These surgeons who have done, they learned and they replicated the technique. Then there are further modifications, like a Mexican group has developed mini slat for pterygium surgery, Garmo-Muscular sandwich technique. And very recently from Russia, Boris Malyugin group has developed a technique where you don't need fibrin glue, you don't need amniotic membrane, and you can do the slat without all these things, which I think is a very, very good idea. How does the slat work? If you look at, this is a study published by Vikas Mittal in Cornea 2015. He imaged the slat patient every other day with fluorescent staining, and you can see the epithelial healing, you clearing, or the staining not taken around the explants. And as the time passes, this clearing, the stained part is less and less. When you compare this with the healing pattern, what we see, this is the cultures in the lab. You see the corresponding here in day 3, day 7, day 10, you see the corresponding culture. So it is very well correlated with the lab cultures and what you see clinically. The clow, which is a traditional technique from since late 17s and early 80s, conjunctival limbal autograft, where we used to put a small segment of the limbus, and the cells will grow from there, and the central cornea will heal the last. With slat, what you are doing, you have many explants. The cells are growing from 360-degree all in from each explant, and then they merge and form a monolayer, and then a stratification. So 3 techniques of limbal stem cell treatments are simple limbal epithelial transplant, cultivated limbal epithelial transplant, and conjunctival limbal autograft. If you assess them on 7 criterias, the basically slat has done what incorporates the advantages of both the technique, and reduces the side effect or downsides of both the technique. On these parameters, either it is better or similar to the other techniques. And this is a high resolution ASOCT images of an SLED patient post-operatively, day 1. This shows further healing, and by about 6 weeks, you get a monolayer, and in about 8 to 12 weeks, you get stratification, and in 6 months, you'll have a very normal-looking cornea if it has worked. So the mechanism of action of SLED is not very complicated to understand, that it is a mini limbus you are transplanting. It has mesenchymal cells, it has other cells, other factors which are secreting exosomes. And what has happened in last maybe 10 years, the number of publication, number of countries reporting the studies from different countries is increasing. And most important, I think most impactful paper I feel is 2021-22 we published along with a health economist scientist from University of Sheffield, that the cost of the surgery of SLED is 1/10 of CLAT. So therefore, it basically democratizes the stem cell transplant. It doesn't depend on the center. It depends only on the surgeon and the patient. So in summary, the SLED is very effective, replicable, repeatable, affordable, and reliable technique. And it's a open platform technology, not patented or not owned by anyone. And there are innovations reported from different part of the world. So the stem cell, limbal stem cell deficiency used to be a problem about 20-25 years back, but no longer. There are very simple and effective treatments available, which the results are quite stable. Thank you very much. Question, comments,
Thank you,
or
Professor.
people are hungry maybe.
So any questions?
That was very informative, Sangwan.
Thank you.
I have basic questions. When you have the slit, the limbal cells will be in the center of the cornea. For maintaining the corneal epithelial cells in the future, will they be the same site or will be reconstructed to be at the limbal area?
What I've seen is that if you follow long enough, and if the initial damage is not very severe, in 2 to 3 years, you see the reconstitution of the limbus at the original site. You will see the pigmentation, the cells will migrate there, and they will regenerate. And I believe that there are variable amount of stem cells remaining at the site in the recipient eye. So they also start functioning.
So some of these transplanted limbal cells on the corneal surface will be reconstructed in the limbal area.
Yes.
In the future.
Yeah, they
Has
migrate
this been
there.
studied? I mean,
It's very difficult to study this phenomena because when you are doing autologous, how do you? There are no definite markers, stem cell markers, and if it is autologous, there is no way for you to image or take the cells. What I am doing now, I am the patient who underwent SLED for say 5-6 years back. Some of them develop cataract. So when I do cataract, I am taking a small biopsy and from the limbus, and then I'm culturing and doing the gene expression analysis and all the ultrastructure studies. So maybe maybe another year or two, we will publish that data.
Another question. Sometimes we face with partial limbal stem cell deficiency, where conjunctivizations and inflammation as well, only in half of the cornea, and the other limbus is free.
Yep.
Have you done this?
Yes.
With just partial from the same eye
Same
or
eye,
from
yes.
that?
Yes,
From the
sir.
same eye.
Yes, yes. There is a paper that we published in 2013 in Archives of Ophthalmology. Now it is called JAMA Ophthalmology. So we compare the in partial limbal stem cell deficiency, if you take the biopsy from the same eye versus if you take the biopsy from the other eye. So that essentially answered this question. If there is even 2 clock hours of healthy limbus in the affected eye, I think you can take from the same eye.
Yes.
You don't need to touch the other eye. And I've done a very large number of patients like that. So I will not go to the normal eye as long as there is some healthy limbus in that eye.
I have encountered in the last year one patient who had bilateral partial limbal stem cell deficiency with corneal scarring, and the only systemic disease, no ocular history before, is Addison's disease. Did you come across any association between this and Addison's?
No, I have not come across. Maybe this will be a very interesting case. So if you have some healthy limbus, and if his vision is affected, see if there is a peripheral vascularization or peripheral pannus, vision is not affected, and patient is not bothered cosmetically, then maybe don't intervene. If the vision is getting affected, then I strongly suggest that you can do a autologous slat.
Okay. Do you like to make any comments regarding allograft and techniques for this, or you do limbal?
No, the allograft I do, the technique, surgical technique is exactly the same. The key difference is the immunosuppression. And I strongly believe that immunosuppression is the key, and I use 3 drugs for a limbal allograft: systemic steroids, cyclosporin, and azathioprine.
For allograft, there is no risk of having limbal stem cell deficiency for the donor.
No.
So having, why you don't take the whole area of limbal and put it in the other limbal in the recipient cornea?
No.
Do you find this better, or?
No. I didn't understand. You mean that from the donor eye, I can take 360 degrees?
Yes.
No, that won't be a good idea, because you will some amount of donor deficiency. So you may be able to take care of, if you take 3 to 6 clock hours, still that is okay. But if you take 360 degree from the donor eye, you mean the cadaveric or from the live?
Cadaveric.
Cadaveric is fine. Cadaveric fine. But remember, cadaveric versus healthy, live, the success rate of recovering the stem cells is only 50%. In 2003, 2004, we published this particular, because I was having a firm belief when I'm doing allograft, I want the best tissue. Some of my limbal allograft cadaveric did not work well. So I'm giving strong immunosuppression, but cells are not healthy. So then, okay, I asked the question, why is this? Then we took biopsies from the cadaveric, cornea, limbus, and the live related. In live related patients, we could grow the cells in every patient in the lab. From cadaveric, only 42%. That paper is published in Indian
But you
Journal
do the
of
same
Ophthalmology.
technique as slit, or you take limbal tissue from cadaveric?
Yeah, for same cadaveric for slit.
Thank you.
May I ask about your standard post-operative protocol for slit?
Standard for autologous slit would be essentially the antibiotic eye drops for both the donor and the recipient eye for 2 weeks till the epithelium heals. And once the epithelium is healed, you can remove the contact lens and stop the antibiotic. And topical steroids in the donor eye, I would use 4 times and reduce every week 4, 3, 2, 1. So 1 month you stop. In the recipient eye, I will start 8 times and I will continue for 2 weeks, then reduce to 6 times, then 5, 4. So you will manage that based on your each case, and you use more slower taper in the recipient eye, and then lubricants based on your requirement. These are the only these are the only medication.
I've got one question, and just following Dr. Raji's comment, and question about whether in the limbus there are resident cells or there are the alien cells. I mean, is it possible if you're doing an allograft and you take a female donor relative, and then later on you can sort of a karyotype the limbus when you're doing a cataract surgery, and you can find out whether these are the resident cells or the alien cells, isn't it?
Yeah, that's possible, but this work we've done in 2005, 2006, and there is a report of a similar kind of work when your donor is, say, donor is female and the recipient is male, and you can do the by FIS analysis afterwards. And I did 2-3 patients, but what I started realizing, when you're trying to pick up the cells, even with impression cytology, you may cause epithelial defect or rejection. So really did not pursue it further, because intellectually it makes sense for us to find out, but for patient it might be difficult. So after that, I don't see any data. Nobody has published.
Yes.
There was a paper in Rabbit by Professor Fundenberg in which they did human limbal transplantation in rabbit LSCD patient, and they then try to track it. So for me, intellectually, okay, it is satisfying, but for patient, you may create more problems. So more important that you want your patient to be, stay healthy and safe, whatever you have done, as long as it's working.
Yeah, thank you very much. And I really would like to congratulate you on this simple and smart thinking of slit over clit, because clit may sound fancy with lab and taking cells and cultivating cells over sheets and so, but there is no lab better than the eye.
Yes, absolutely, absolutely.
And it cuts the story very short. You take the cells immediately on the cornea, and there is no comparison actually. It is simpler and it's smarter and it's faster and really very impressive. The thing is that you put the cells on the center, and let's say that you in the future want to do, for example, a keratoplasty, and you said that the cells might, with time, go to the limbal area. So how long will you wait before considering keratoplasty if you want the cells to go to the periphery?
I think I will wait at least for a year. And there is a very good paper that we had published in AJO. I think this must be around 2014, 2015, when we were doing cultivated limbal epithelial transplant, and around 15 to 20% of those patients needed PK. So we have published that data of PK post clat, and then the survival of that PK, how long it lasts. Because if you did not have enough stem cells in the limbus, then it cornea will fail very soon, because the donor cornea does not have stem cells; it has only transient amplifying cells. So in that we found that the average graft survival, I think, around 4.5 years or something. So I would wait for 1 year minimum, and then decide about PK or DALK. But one observation I want to share with you, uh, when doing SLET, there is another advantage, that the patient who need PK or a DALK is very less. If you wait long enough, if it is not a pediatric patient, if you long enough, your mesenchymal stem cell will clear that anterostromal scarring. If it's a very deep scar, then it will not get cleared.
Then waiting is better, actually.
Yeah, waiting is better.
The other thing regarding the cadaveric stem cells is very much expected that the cells will die off with time. And no one will take a kidney from a cadaver after, for example, 3 or 2 days, or a liver or whatever. So I think the stem cells will be more or less similar to this. They may last longer than a kidney or a liver, but ultimately they get damaged soon.
Yes, and that medium, the storage medium, is designed for endothelium, not the epithelium.
Even few days, I think it will not, for
Yeah.
stem cells, few days are not okay. You know what? And I think that's why they fail, because they need to be treated exactly like a kidney or a liver or whatever.
See, for me, if I
these
do
are
allograft,
vascular areas.
if I do allograft, I always do live related, and that I switched in 2002, 2003, because I was very convinced that eye bank donor corneas, the stem cells are not there. I'm just making my patients suffer by giving strong immunosuppression, and those cells don't last. They don't have good vision. So therefore, I switched and then produced the evidence that what I'm thinking is actually true at the cell level also.
Yeah, I think the concept that the stem cells in the cadaver can wait for 2 or 3 days, I don't think that this is really correct. As quick as the kidney and the liver disintegrate, the stem cells in the cadaver will do so, because they depend on the blood vessel.
Thank you. Did you encounter failure of slit at the beginning, and do you have to repeat it, and how frequent do you repeat?
About 20%.
Do you repeat it the same way?
Yeah, I will repeat the same way. So see, the when any stem cell procedure fails, it is not just stem cells. Your environment, meaning the recipient tissue, also has to be healthy. If it's too deeply affected, then whatever you put on it, it will not grow. So if the burn has been very severe, then whatever you put, it's not going to support. So chemical burn, all chemical burns are not same. Say thermal burns, outcome with slat is not good. The lime burn is the best, then acid burn, then maybe other kind of burns that batteries and other things. Firecracker injury again does not give very good outcome.
Now, we have seen cases, and I don't know if other people did encounter the same or not, when we have to do sclerocornea graft, when you an infection or sometimes in chemical burn, and you transplant sclera with a cornea tissue, and surprisingly, without using a lot of immunosuppressive tissue, still you see there is a full epithelialization of the cornea. Did you see that?
Yes. See, that is explained by the fact that for as long as there is a physiological demand, the epithelium can maintain. If there is a injury or infection, then your epithelial is under stress, and then you will start developing the melting or the LSCD. Say, for example, you have a patient with VKC. Persist limbal inflammation produces dysfunction, but their cornea can be maintained clear for a long time, as long as there is no injury or there is no infection. But the moment they encounter any small epithelial defect, it will not heal very easily. And that's why in patient with Steven Johnson, the epithelial defect healing is such a major problem, because whole environment is very hostile. There's no stem cells, there is no other factors which are helping. So it matters, all these factors will matter towards healing.
I think if I understood the question was because you are taking a very big tissue and you are removing the corneal scleral the cornea, so there are no stem cells there, and no stem cells in the donor cornea.
So that's what I'm saying. The donor corneal stem cells, even if there are or they are not, the epithelium on the cornea has transient amplifying cells.
Yeah, those.
So as long as they will be able to maintain the normal physiology function, but not pathological requirement. Right?
Sorry, yes. The transient cells are.
Yeah. Yes, sir. Yes, they will fail.
I have just, it's very impressive technique, and I think I just would like to know, when you do autograft, you didn't need any workup for the patient, but for allograft, for the donor, do you do any workup like other organ transplant, or just you?
2-3 things that if generally I take a patient who is live related, so they are family members, so I don't do serology, or I just rely on the history. That if they say we don't have hepatitis or HIV, everything is fine. Only thing I do is detailed ophthalmological examination of the anterior segment, fundus, everything, just to document and make sure that donor site from where I intend to take the tissues, that is healthy, and I may not want to create any unintended side effect for the patient.
No HLI typing or anything?
No, not required. Not required.
Okay, thank you.
In situ you can't, there is no markers, but in the lab, yes, we do markers. When we are growing cells, then you do all the markers, but in situ in patients there's not possibility. There are no such markers commercially available.
You mentioned that sometimes you do after OSSN excision.
Yes.
I have done a lot of OSSN excisions. Some of them are extensive. And I usually wait because some of these limbal systems, especially if it is not 360 degrees, they might grow and get clear cornea before attempting any limbal stem cell transplantation. Do you do the same thing?
No, that is, I mean, that's fine. If that works and you are happy with that, then there's no need to combine. But my experience, I came from a patient who underwent OSSN surgery and developed LSCD, and then in 2000, early 2005, I was doing cultivated limbal epithelial transplant, and that in a patient who have undergone OSSN or chemotherapy for the OSSN, the success rate was not good, and that is why I started teaching this doctor And somebody reported the outcome of primary SLET in OSSN, and large OSSN. Then I started teaching this young lady about how to do this SLET, taking biopsy from the same eye. So for her, it has become a very simple procedure. So instead of waiting and see whether they will develop stem cell deficiency or not, where you think it's like 4 or 5 clock hours or bigger, then you combine with the SLET.
I have a question. I don't know if I missed it in your lecture. How long, what is the average and range of these transplanted limbal stem cells over the cornea become flattened on the cornea?
You mean the explants?
Yes, the one you
put when we put the explants.
Correct.
Yeah. So the again, I'm comparing with the cultivated. When I was doing cultivated, the explant will fall off within a day or two. Only will the epithelium monolayer will remain, and that grows. Now, when you do SLET, these explant can last for a year, 2 years, sometimes 3 years also. So therefore, what I advise, if you have a very clear cornea, like today, the second patient we did, his cornea was very good. So central 4 millimeter, I don't want to put any explant in the visual axis because they may persist and they may get integrated in the epithelium and they will degrade the quality of vision. So I keep only paracentral and peripheral cornea.
This will not cause any foreign body
No,
sensations.
that won't. No, it will not cause. Yes, sir.
I hope this is my last question.
No, we can keep
Is
asking.
it possible to do it with the femtosecond? I mean, to cut the limbal stem cell by laser rather than surgical technique?
Yeah, I'm sure those who use laser, I don't use very often. It would be very expensive way of doing it. But if people who do fematocataract and fematocataract doing the rexes and other part, similarly, I'm sure you can do femato cut with the biopsy. It would be very clean.
It will be clean and more regular. And second,
so you have the femato.
Yeah.
Please try.
Second, when you put these small pieces of stem cell taken from the limbal, what's about if you make small spots on the cornea where you could put these pieces of the stem cell in it rather than just put it in the surface?
So this is what Malugan has done. So instead of making on the entire surface, they made pockets in the periphery at the limbus, and they did not use fibrin glue. They stuffed those small pieces, 6 to 8 pieces in that pocket, and put a BCL. And they have earlier they published a case series of 2 patients, and then later they have published 6 cases in cornea last year. So it's possible in different ways. Because for me, this is how the technique works. So I feel that, okay, if things are working in my hand, why do I need to change?
If I may comment on using the femto, I don't think that is going to cut nicely because
Transparency.
the periphery of the cornea is opaque.
And also it needs transparency.
It's the part of the cornea is transparent, the other part is opaque, so it will not cut. And even if it does, you need software actually, a lot of programming, but it will not cut. The one just a theoretical issue. Let's say that a patient with, let's say, OSSN, bad OSSN, is going to undergo, let's say, chemo therapy, and we expect the chemo to damage all the stem cells in a variable way. Is it possible to take part of the healthy stem cells and reserve them, freeze them, keep them stored until the cornea gets treated and the OSSN is eradicated, and then maybe later on can be transplanted? Is it possible for such a thing?
It is possible. I had worked on this idea long back, but not really seriously about it. But see, if human sperm and ova, which are stored for patients who undergo chemotherapy, and they are revived after many years, so I would assume there is possibility, but I have not done myself. You can take the biopsy, you can put in -80 and some medium, and after several years or after 6 months or 1 year, if you want, You can grow, or you can do the directly slat.
Then I think this makes us more, comfortable in using the chemotherapy because sometimes the damage to the stem cell is a concern. For example, mitomycin works very well, but because of the stem cells, we do not liberally use it. Thank you.
Thank you, Prof. We can have 15 minutes break. Okay. Assalamu alaikum. Good afternoon. So my talk today is more of an overview to high-risk penetrating keratoplasty. Penetrating keratoplasty is the most common form of solid tissue transplantation, and the high success rate of uncomplicated avascular low-risk beds contrasts sharply with the corneal graft placed in the so-called high risk, in which rejection may approach up to 70% in vascularized beds. Immune-mediated rejection remains the leading cause of corneal transplant failure. Now, two factors play a key role in PK success: the unique anatomy of the cornea and the degree of the vascularization and the condition of the host bed. Now, in this talk, I'm going to address two questions. What's a high-risk keratoplasty and how to approach these cases? Now, when someone tried to define a high-risk keratoplasty, there is a definition for this. And in the collaborative corneal transplantation study, the high risk was defined as a cornea with 2 or more quadrants of vascularization in which graft had previously been rejected. Now, when approaching these cases, the approach is a bit lengthy, and it starts before and during and after. So in a way, you are bound to the patient in these cases. It's more of a timeline. So what you do before and after is really important as what you do during the surgery. Now, there are few etiologies that put the patient at a high risk of failure, and we consider as a high-risk keratoplasty, starting with corneal stromal vascularization and prior graft loss, and increased graft diameter or eccentric graft, anterior synechiae, glaucoma, previous intraocular surgery, ocular surface diseases with severe ocular inflammatory diseases or herpes simplex keratitis, and finally, pediatric keratoplasty. Now, in the collaborative corneal transplantation study, a high risk was defined as 2 or more quadrants of deep stromal vascularization. In this study, the risk of rejection was doubled, assuming that we have 4 quadrants of vascularization, but not the degree, only the depth of preoperative corneal vascularization determined the risk of rejection. So what causes corneal neovascularization? In a series done by Professor Dua and his group, viral keratitis was one of the leading etiologies for corneal neovascularization. Now, loose sutures are potent stimulus for vascular ingrowth and vascularization of the cornea. They attract vessels, mucus deposits, inflammation. They increase the risk of infections and rejection. So whenever there is a loose suture, this is a risk for infection and suture abscesses. You may lose the graft and you may lose the eye. So it has to be removed. So why corneal neovascularization treatment is needed? Because a prolonged presence of vessels may induce corneal deposits and scarring and lipid deposits, and there is an increased risk of rejection. So how do we treat corneal neovascularization? We start with treating the stimulus for corneal neovascularization, vascular occlusion, and finally, preventing proliferation. So what kind of modalities do we have? We can suppress the inflammation with steroids. We have the laser, we have the anti-VEGF, and we have the cautery, and finally a novel technique called mice that I'm going to talk about in detail later. So steroids is the mainstay of treatment. It acts on inflammation, it suppresses any active proliferating vessels, and it has anti-angiogenic effects. It is the mainstay for any vascularized cornea. And argon photocoagulation is another modality where we can use it with a laser spot of 50 to 200 with a power of 200 to 500 millijoule and duration of 0.5 second. Another common modality that is used is the anti-VEGF, where we can use it either topically or more preferred is in injectable anti-VEGF. So topical, you require a longer duration and a high concentration where it is associated with more ocular side effects and epithelial defect. However, on the other hand, the injectables
tend to yield a better results, especially if used early in the disease with insurance of compliance. Another technique is the fine needle dithermy, where we use 1009 nylon suture applied at 50% depth with electrocautery for 1 to 3 seconds till we see a blanching effect. This is a simple technique, effective. However, it can be associated with complication, astigmatism related to the scarring or intrastromal hemorrhage. Now, in a study that looked at the long-term outcome of fine needle dithermy for corneal neovascularization, the success rate was 70% in the first treatment and 90% for those patients who received 2 treatments, with a significant improvement of VA in patients with herpes simplex keratitis. Another study that combined fine needle dithermy with adjuvant bevacizumab, the VEGF, to treat corneal neovascularization related to herpes simplex in children, and the success rate also was encouraging. The series showed resolution of scarring and vascularization in these patients. Another novel technique that I want to talk about that was recently published by Dr. Dean Uwaino, using the mitomycin in a small needle. This technique is inspired by the use of chemoimmobilization in treatment of hepatocellular carcinoma. So the rationale is to selectively deliver the mitomycin in the corneal vessel, where it may induce apoptosis in this vessel and induce regression of this vascularization and disappearance of these lipid deposits. So how do they do it? They locate the afferent vessels, and they use a very small needle, 33 to 34 tuberculin needle, with a 0.4 milligram mitomycin, and then they inject within the vessel a tiny small amount of 0.01 to 0.05 of mitomycin. The results shown in the photos of this study were encouraging. It tended to increase initially after the treatment with some sort of deposits and hemorrhage, and then with time it whiten and disappear as the weeks goes on. These pictures are taken from the study of Dr. Dwayne Uwaino. Very interesting technique. It was used on lipid deposits and corneal vascularization related to herpes simplex vascularization. So pre-treatment of vascularized cornea is key. Combining therapy is an excellent strategy, and if the stimulus of vascularization persists, of any form of vascular occlusion will be temporary. It will come back again. So another challenging situation is PK in herpes simplex disease. So one of the leading diseases for unilateral corneal blindness is herpes. It's a common indication for keratoplasty, and the 2 indications to do keratoplasty for these cases is removal of scar and restoring the integrity of the globe in cases of melt and perforation. Preoperative measurement that can be taken in these high-risk cases is control of the inflammation, treating the vessels, assessing the sensitivity so someone can prepare themselves with AMTs and serum BSS, and antiviral prophylaxis ahead of time. So the first step in doing PK in these cases is controlling the inflammation. So the medication that we have tend to control the inflammation by 50 to 80%. Pre-treatment is mandatory with antivirals and steroids. Vascularization, again, we can repeat what I mentioned before: steroids and anti-VEGF, laser, fine needle dithermy, and mice are the modalities that we may use in these cases. And assessing the sensation is also key in identifying the etiology ahead of time, and also preparing ourselves to healing issues. So those patients tend to come with hyposthesia and may be severe enough to reduce the healing and may necessitate the use of AMT on spot. Recurrence is also an issue. So long treatment with systemic antiviral has been proved to be effective in preventing recurrence. So both Valtrex and acyclovir are good medication. Whatever you have at your disposal, those 2 medications are safe and works very well in herpes simplex disease. Now, what about the question of DALC versus PK in herpes simplex disease? So in a study that looked at DALK, this question, DALK versus PK, DALK performed better than PK, assuming that the scar and vascularization is superficial. They had less episodes of failure and less episodes of rejection compared to the PK group. But sometimes the scar is deep and the endothelium is affected, so PK is necessitated in these cases. Now, PK in herpes simplex diseases, the post-operative management should be focusing on controlling the inflammation with topical steroid, usually prescribed with a high frequency, consistent with the degree of inflammation. Sutures should be removed as soon as the wound heals, and persistent epithelial defects are common, and sometimes confusing whether it is a recurrence or whether it's a healing issue. So one should treat both at the same time. So differentiating recurrence versus rejection also in herpes simplex disease is difficult. So it is extremely difficult, and they can occur simultaneously. So using prophylactic antiviral will prevent you from facing this situation with the intense topical steroids and will improve the survival rate. Now, another etiology for having a high risk keratoplasty is a prior graft loss. Prior graft loss is a significant risk factor to develop graft failure again. Graft rejection occurs earlier, more aggressive in cases of regraft, and the cornea donor study has shown increased risk of graft failure in those with a history of definite graft rejection episodes previously. The 10-year graft rate among those patients was 12% with no graft rejection. However, 22%, double with the patients who had definite rejection before. Now, in this study that looked at first graft versus regrafting in keratoconus, the patient who had the first graft had a better outcome compared to regrafting. Again, the regrafting had more issues and more difficulties in managing their post-operative outcome. Now, managing post-graft failure is different depending on the etiology, assuming that there is no stromal scars. Endothelial keratoplasty is the treatment. A repeat PK where there was a bad visual outcome with a graft failure previously. Boston Kipro, where we think PK won't survive, and observation when there is no visual potential. Anterior synechia is another issue where there is a direct contact between the graft and the host vascular system, where those patients are prone to glaucoma and elevated IOP, and there is a traction between the iris and the endothelium that may induce a progressive cell loss and put the patient at risk of graft failure sooner than others compared to those with no anterior synechia. So the direct contact poses a significant risk. In this study also, just like vascularization, 3 or 4 quadrants doubled the risk of failure and rejection compared to those with no synechia. So if possible, treating these synechia, releasing them, synecholysis, and probably surgical PIs and viscoelastic agent are helpful in releasing the synechia. However, these synechias tend to have memory and they may come back. So another issue that poses a risk for failure and rejection is a previous intraocular surgery. Those eyes are, because of lensectomy, vitrectomy, and elevated IOP, are at chronic low-grade inflammation, so they tend to predispose the patients for rejection and failure. So inflammation at the time of surgery is a significant risk factor for rejection and failure, and keratoplasty should be delayed for a period of 6 to 12 months. A strict control over inflammation will help in getting a good outcome. Now, another entity, since we have keratoconus commonly here in our country, is post-keratoplasty atopic sclerokeratitis in keratoconus patients. Those patients tend to come with an aggressive loosening of suture, corneal neovascularization, persistent epithelial defect, and graft melt. It's a severe complication in atopic patient undergoing keratoplasty, and systemic immunosuppression should be considered ahead of time in patients with active blepharitis, blepharoconjunctivitis, and corneal neovascularization in the history of atopy that will undergo DALK or PK. Another difficult etiology is Stevens-Johnson syndrome, mucous membrane pemphigoid, chemical burns, and aniridia. Pediatric keratoplasty is also another difficult cases for another difficult indication for keratoplasty and put the patient at high risk. Also, graft diameter, whether small or large or eccentric, will increase the risk of failure and rejection. So, in the clinic, ahead of time, risk stratification and discussing the outcome, knowing that the etiology and discussing the etiology with the patient and explaining for the patient that each indication is different from the other indication and the outcome is different from your neighbor or your friend who had keratoplasty is key also to satisfy the patients. The clinical management starts with minimizing the ocular inflammation. Whenever it's possible, penetrating keratoplasty should be delayed until inflammation is controlled for a period of 6 months. So severe chronic diseases should be treated and the patient should be in remission for a good period of time. Healthy ocular tissue is essential for the success of PK. Treating the lead diseases, entropion, ectropion ahead of time, treating with the blepharitis, punctal occlusion, tarsorrhaphy, whatever it takes to let the graft survive is also helpful to achieve a good outcome. So intraoperatively, what do we have in our hand? We have ensuring that we have a good quality of graft for those patients who are prone to risk. You want to eliminate another confusion. Interrupted sutures where you can modulate the management, release of synechiae, surgical PI, treating and addressing the vessels, subconjunctival injections of steroids and Avastin will help. Post-operatively, patients' education and strict follow-up is key. Topical medication and systemic immunosuppressives also are key in achieving good outcome and management of the complication that possibly will develop in those patients. So the basic goal is to prevent rejection, early recognition if it occurs, to prompt treatment, and teaching each patient the symptoms of rejection to facilitate early rejection, a useful thing to do. So educating the patient about redness, sensitivity to light, visual loss, and pain will help the patient. Frequent follow-up. Those patients tend to be bound to the cornea and external disease clinic. They have to be followed regularly because of their high risk to develop complication. Because if you catch them early, the chances of having a good outcome is higher. So one of the questions that will keep coming with those patients is rejection versus failure. So one of the outcomes that you may face after keratoplasty is a primary donor failure, or a graft failure that is defined as a graft that never clears after immediate surgery related to a donor quality or surgical trauma or improper storage issues. This is more of non-immune phenomena related to the graft itself. And the treatment for a primary graft failure is simply repeating the graft. However, the graft rejection is more of an immune phenomenon where the patients tend to present with redness, blurred vision, photophobia, epithelial stromal, and endothelial rejection sign, and irritation. And they may present with rejection lines, subepithelial infiltrate, AC reaction, KP, and falls and graft edema. And the treatment here is different. The treatment here is steroids and immunosuppressive medication. So the progression from rejection to failure may reach up to 49%. It depends on what study you look at. And beside all the classical signs, with high-risk keratoplasty, one should be vigilant and treat aggressively any single new keratic precipitate or anterior chamber reaction or asymptomatic subepithelial infiltrate or conjunctival inflammation. So how do we treat this patient? The mainstay is topical steroid. A high potency and more frequent steroid is needed in these cases. Long treatment, sometimes indefinite, assuming that there is no contraindication. However, if there is, Lotimax is a good option. It may be considered as an alternative for the conventional steroids it drops in patients with ocular hypertension. Patients may need systemic doses of steroid of 1 milligram per kg around the time of surgery, which can be tapered and individualized 1 to 2 months until the immunosuppressive kicks in. Now, topical cyclosporin is also another modality that is proven by a different study that inhibits the T cell activation and act promptly on interleukin-2. It has an additive effect on topical when combined with steroids. So systemic immunosuppression, cyclosporin can be used especially in patients with who are monocular or in a very high risk cases. So several studies demonstrated that systemic cyclosporin can be effective in preventing corneal graft rejection. Systemic cyclosporin is a valuable tool, especially in patients with atopy, and it should be considered as a long-term strategy because the effect wanes away once you stop the medication. Patients with atopy experience a decreased incidence and a better survival and improved outcome when used with when using cyclosporin A. The side effects may range between high blood pressure, increased hair growth, swollen gums, and elevated liver enzyme and creatinine. Now, topical tacrolimus is one modality that is now commonly used and has been used off-label as a second-line agent for cases at high risk, especially with vascularization. And a recent study that compared topical tacrolimus combined with steroids to those who took steroids alone, the people who took tacrolimus and steroid did better than the people who took steroids alone. So topical tacrolimus also was compared to cyclosporin in another study, and also the patients who did take topical tacrolimus did better than cyclosporin A alone. Systemically, tacrolimus has been found to be effective in preventing rejection and risk of graft. There is also some evidence of superiority of systemic tacrolimus when compared to cyclosporin A, and the side effect range between hypertension and renal toxicity. Another treatment is CellCept, mycophenolate mofetil, which is antimetabolite that acts on both T and B cells. CellCept is a benign medication and it decreases the incidence of immune reaction and may be promising systemic treatment for high-risk keratoplasty. It has some side effects, and all of them are reversible between GI toxicity, arthralgia, and tachycardia. So given the safety profile of CellCept, it's an effective strategy for high-risk keratoplasty as a single agent for long-term maintenance. Systemic cyclosporin and tacrolimus are also good second agent with CellCept for patients with high-risk keratoplasty. Another issue is the post-operative complication that one has to be ready to deal with after high-risk keratoplasty, starting with graft rejection failure, redevelopment of the original disease, melting, infection, persistent defects, synechia, and glaucoma. So one has to be prepared for AMT, tarsorrhaphy, surgical PI, and glaucoma surgery, and limbal cell transplantation. So in summary, in high-risk keratoplasty, an appropriate strategy to start first by treating the eye, preoperatively identifying the etiology before proceeding with keratoplasty, educating the patient about the signs and symptoms so you early intervene and improve the visual outcome in these cases. Intense topical treatment with the steroids, cyclosporin, tacrolimus is helpful to be continued for a long duration, and systemic CellCept is an effective treatment for high-risk keratoplasty as a single agent for long-term maintenance with a good safety profile. A good alternative is systemic cyclosporin and tacrolimus that can be used as a second agent to CellCept, which in cases of high-risk keratoplasty. Thank you.
Thank you, Dr. Mutlak. Any questions from the floor? We all deal with high-risk corneal transplants all the time.
Well, it depends. So in cases of atopic patient and keratoconus, as I mentioned earlier, I start cyclosporin. If I feel like that this patient is atopic, I may need anything. But in cases where this is a repeat graft, monocular patients, I recently started to give patients CellCept, and I noticed a good outcome with the CellCept.
For how long?
So I kept patients for 1 year or more, but I did not continue for life for these patients. No. Mm. Mm. So, yeah. So I have a
No, yeah. So CellCept is very safe, as Dr. AlMutlak is saying. So usually I give 3 months of oral steroids. I start with like 1 milligram per body weight, and then I taper it after 2 weeks, and then I tend to stop it by 3 months or bring it down to 7.5 milligram, and I can continue. And CellCept, I used to use tacrolimus, which we don't have it in KKS yet, but that is probably the best drug if you want to do a high risk corneal transplant. But CellCept, I keep it till I have removed the sutures at least. It is available. I mean, and we were talking yesterday. I mean, it's just expensive, but we are bringing it to KKS, inshallah. It will be very soon. So for our high risk cases, tacrolimus is probably the best immunosuppressive agent.
I have patients who have or
do you engage internal medicine with the care, or?
I think it all depends upon your confidence. Like I don't, because I was trained in uveitis and I worked in Morpheus for 3 years and we were playing with it. Dr. Sangwan, again, trained at Massachusetts. So people who feel comfortable, they're doing it. Otherwise, there is no harm in asking the internal medicine and rheumatologist and their output. I mean, whatever you feel comfortable with.
So here we do ask them, but they tell us you can start it by your own. There is no need to clear it from our side.
You should, either if you are going to deal with these kind of problems, better that you equip and learn over a period of time, because it is much more efficient and effective. Say if you collaborate, and then it's very difficult to convince them what dose. They have their own beliefs and their own way of treating. So I realized that very early on, and that's why I went for a fellowship with Dr. Foster, and I wanted to use these medicines myself. But if there are systemic issues, then of course you collaborate and work with the physicians.
I feel that topical cyclosporin
of treatment. Yeah.
It's more like a homeopathic drug. I mean, I think you treat yourself with cyclosporine rather than the patient.
No, it's not effective at all, and there's no point believing that it works. Because rejection and inflammation is a systemic phenomenon. So you need to start, if you are serious about those things, you need to start systemic. Topically, it gives you a false belief that, okay, it will save the graft.
So
it's not really.
What about topical tacrolimus in your experience?
Same topical tacrolimus for high risk graft. I don't think it's a really useful technique.
Yeah, other problem is that they do not penetrate. Cyclosporine and tacrolimus. So,
I think they have new vehicles that can penetrate the cornea. It used to be olive. That is very difficult to transfer the epithelium.
Still, I mean, all the commercial available, and there are 2-3 coming in the market now in the last 1 year or so. They're all for the ocular surface. So none has been approved for intraocular use yet. And tacrolimus, there is an ointment available in India. Otherwise, there are drops available in Japan, but they are for ocular surface indication, like commercially. So none of the commercially available drops or ointment are for controlling the intraocular inflammation or like uveitis or rejection.
So I have a question to Dr. Sani. One of the pictures here Dr. AlMutlak has quoted is Orolab 2% cyclosporin. This is readily available in India, right?
Yeah, yes. So cyclosporin, because that 2% is very good for the surface allergies, like mild VKC and other inflammatory disorders, not really for graft. I don't use for graft rejection.
So
see, high risk graft, the autoreactive T cells are in the lymph nodes and other lymphoid organs. So that is the manufacturing site. And when you use systemic, it's not only protect the graft, it also reduces future antigenic load and the autoreactive stems, the lymphocytes.
Now, I'm just curious about availability of tacrolimus, commercially available drops, also in India.
No, drops are not available. Ointment.
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 But it is an ophthalmic preparation.
Ophthalmic preparation.
Because I took this from one of our ophthalmology meetings that is available in India. We don't have it available here unless it is prepared or a skin preparation.
The tacrolimus eye ointment, there are 3 companies, which is ophthalmic preparation.
So, but I think topical tacrolimus works because we do DALC a lot in keratoconus. I think tacrolimus works in these cases where
as long as endothelium is safe, then I think you can use it. Yeah.
Okay,
great. Thanks a lot. I think we'll move to the last talk of Dr. Sangwan again, and it will be about the management of VKC, and hopefully we're going to learn something new. Thank you.
All right. So VKC, I think it's very common here. We see very, very often in India also. And here the main cells which are main culprit is the mast cells and eosinophils. I'll share you this patient who have been managed at LVP since 1988. And he was quite young boy at that time. And he had a very early mild disease. He was treated with the topical, traditional medicines. But over next 7 years, he developed very severe ocular surface inflammation and the limbal dysfunction. And then I took over and started treating with systemic steroid and systemic methotrexate. And then he developed cataract for both eyes, which I did cataract surgery in both eyes, phaco. And you can make out there is a peripheral, sort of pannus and loss of stem cells. You can make out here more clearly. And central cornea is okay. Especially the left eye is better. The right eye has some scarring. With the pros lens, he could still see 20/30, 20/40 vision in both the eyes. So if you manage the inflammation well, and despite having severe inflammation, these patients can see well. And in some of these patients, I don't do limbal allograft. If like in this patient, I did the removal of the pannus and did AMG, and that also helped. It does not cure, but it can improve the surface. And with the help of pros lens, you are able to function. This is a patient who I started managing in 1999. A 9-year-old young boy from Uttar Pradesh had severe typical VKC with these are the sealed ulcers and tarsal giant papillae with a lot of epithelial scarring. And you can see more dramatic picture by the time it is another 3-4 years down the road. And he received systemic steroids and systemic and topical steroid, then systemic cyclosporin. And these are the pictures in 2002. So I'm sure these kind of pictures are not very uncommon in your clinics, that the surface becomes so bad, the corneal surface becomes so bad. At this stage, I decided to do the limbal allograft. The tissue was donated by mother and cultivated limbal epithelial transplant. It worked for a few years, then it failed. And he was on systemic cyclosporin and azathioprine. He underwent multiple procedures, cultivated limbal epithelial transplant. Second time I did from the brother, and then did a LK along with the alloclat. And again, that worked for a few years. So that allowed him to continue his education. And then at one stage, I felt there was some limbal tissue normal. So I did a autologous clat. In 2009, we reached a stage where, all these procedures have failed and there is not much, and he's not able to go to school. So at this stage, we did a Boston type 1 keratoprosthesis in the left eye. And within a week or so, he improved his vision 20/25. And this vision is maintained till 2014, 2015. And then he developed glaucomatous, cupping. He underwent Ahmed valve. So around 15 years, 12, 13 years, it went well with the different procedures. Then now it's not included in the presentation. The left eye, the K-Pro vision has gone down 2040 or 2400, and I've done the yellow slat in the right eye from the sister, and then PK, and he's doing very well. This is a patient where I showed in the previous presentation, Abhishek Sharma, bilateral limbal stem cell deficiency in 2001, and he underwent, this is the AlLutlak tissue donated by mother, and I did both the eyes 3 days apart. And this is in 2004. His right eye 2030, left eye is 2000, and use on systemic cyclosporin, diltiazem. And then at one place, if you see here, there was an area of redness. I felt there was a graft rejection, because I was also new doing these cell transplantations, and the signs of rejection I could identify as with redness. So I treated him with IV methylprednisolone, increased the cyclosporin, and he did well. And since then, he has been doing quite well, and now he's off all medications. So in VKC, we see so varied presentation, so much of diversity and effects in the limbal stem cell deficiency. Now it is recognized. Earlier, when I started in 98, 99, this was not a known entity. The clinical forms, I'm sure you must be seeing very different forms and different types. I see quite aggressive in certain situations like this. You have these giant papillae with the ropey discharge. Limbal form, again, very aggressive. This can be, variants can be cystic degeneration or limbal dysfunction or limbal hypertrophy. All these are very, especially the limbal hypertrophy is a sign of very active disease. These are other different degrees of severity. And sealed ulcer is almost always associated with palpable form of the disease, not with the limbal form. Generally, we believe that AVKC is a trivial, self-limiting disease, and I have believed and practiced that this is not true. So I started understanding and studying this disease. In LVP, we did in one study, one DNB students, 1 year, all patients of VKC we examined. These are 468 new patients. Out of that, we discovered that 12% of these patients had persistent VKC beyond 20 years of age, and 3.5% had adult onset of VKC, and 5.5% patient had some sort of limbal stem cell deficiency. 33% patient had some blinding complication, and these are some of them are listed here: keratoconus, sealed ulcer, cataract, glaucoma, and corneal scarring, LSCD. Then further we studied the stem cell deficiency in these patients, and we try to understand why this happens. So the postulation is that because you have such a severe toxic inflammatory mediators, loss of goblet cells, conjunctival scarring, SPKs, and limbal dysfunction. Then another student thesis was to document the cytological and clinical evidence of deficiency of LSCD in patients with VKC. And this paper was published. We could show that what we are seeing clinically is also supported cytologically. And then we proceeded with the treatment. This is one patient in the very beginning. In 2005, we published in Cornea. It was very difficult for the reviewers to accept that it is a patient with VKC with stem cell deficiency. So in one patient, I did a limbal stem cell transplant, LO. Another patient didn't want. She was an air hostess in Indigo Airlines. She wanted only amniotic membrane. She didn't want to take any systemic steroids. And the patient with AlMutlak, Mr. Sharma, is still working well. The girl, within 2 years, she had recurrence and peripheral LSCD and decrease in the vision. Other complications which are induced by treatment is cataract and glaucoma. Both of these complications are preventable if we manage them better. In terms of the pathophysiology, the activated mast cells or basophils, they secrete all the mediators, and then the eosinophils they secrete the Ig antibodies, and both these cells are the main actor which causes the surface damage. I don't believe that it is the mechanical irritation which causes the seal ulcer. To me, the seal ulcer is purely chemical injury to the ocular surface, and therefore you need to treat these patients aggressively. Says, for example, the seal ulcer, 3 different grades. You can see the appearance of Cameroon classification, grade 1, grade 2, and grade 3, and these are more example here. So what I treat typically, these patients, seal ulcers, remove that plaque, put amniotic membrane, and give supratarsal steroid injection, and now I use more often systemic steroids. This is one of the largest study published by one of my fellow in 2013. 163 patients with sealed ulcer treated with this AMG, and their outcome reported in AJO. In this, we showed that grade 2 to grade 3 a patient need surgical intervention. Grade 1 with clean base, probably even if you use topical steroids and BCL, it should work well. Overall management of patients with VKC depends on the stage of the disease, age of the patient, recurrence pattern, associated complication, and steroid sensitivity. I mean topical steroid sensitivity. So the management will include mast cell stabilizer, topical and systemic steroids, and topical and systemic immunomodulation. Surgically, mostly I would consider supratarsal steroid injection, amniotic membrane transplant for seal ulcer, and cataract and glaucoma surgery whenever needed. Today I'll share you, maybe this I should show you, this how you give steroid injection, supratarsal steroid injection. Do you use here? So supratarsal steroid injection at the same time when you are doing the amniotic membrane transplant, and this is good triamcinolone or methylprednisolone, and can work for 3 to 4 months or sometimes 6 months, and can reduce the need for topical steroids. I don't use all these topical cyclosporin or tacrolimus. I do use, but other things, mitomycin drops or vasoconstrictor antihistaminics, I don't use. Mostly patanol, topical steroids, and mast cell stabilizers. Systemic steroids and immunomodulator is something that I use, and now I'm in the process of creating evidence what may be the indication, how to use. Because the patient with moderate to severe VKC with persistent inflammation and numerous inflamed limbal infiltrates, giant papillae, all those are indication for systemic steroids. I generally don't start in the full dose, maybe 0.5 to 0.75 milligram per kilogram, a single dose after breakfast. And this is a small study of 29 patients. I will come to the study data. This is a patient which I am sharing, patient of from Nepal, a girl who has bilateral LSCD and underwent a yellow slat. This is the pre-op appearance. This is how her vision is, 660 and 1/60 in the other eye. And she underwent live-related limbal yellow slat. Tissue donor were brother. And this is the one eye, this is the other eye. And this, if you look at the medicines, that topical cyclosporin, azathioprine, 3 dose of methylprednisolone, and tablet visolone, along with topical steroids and antibiotics. This is about 2 weeks later. 6 weeks later, she improved 6.6 in the right eye and 6.18 unaided and 6.9 with the PROS lens. And surface is well epithelialized. Now she is back in Australia and working. And there is a doctor who's connected with me. He is taking care of it. So these are 26 patients who received oral steroids, and some of them received immunomodulator also. And these are the patient, one of my former fellow in Ahmedabad, Dr. Vazirani, and are my patients. Both of us, we treat. And this is, most of these patients are over 20 years. And these are associated systemic allergies in about 11%, other comorbidities, and systemic indication. These are more or less what we talked about. So here, 8 of these patients were on 3 or more topical agents. See, if it is a young child and if you're using too many medication, it's very difficult for the parents to manage, especially school-going kids. So it's very important that you see the compliance issue also. The mean duration of the steroid therapy was roughly about 3 months, and then they were reduced. And some of those who were on 3 patients were on systemic immunomodulation, mostly cyclosporin oral. This is a case example of a patient of mine who had 6/12 vision in one eye, and this is the tapering regimen, starting 40, 30, 20, 10, and then see if you can maintain on 5 milligram for next 6 months or more, so that it's very convenient, unless there is a breakthrough attack. Similarly, another 20-year-old boy with asthma, and these are different cycles of twice, and I think third time we put him on along with the oral cyclosporin. So the systemic treatment is indicated for recalcitrant patient on maximum medical therapy, blinding disease like shield ulcer, or if it's a young child with keratoconus with VKC, I will use systemic medication. Now, there is a good research that we are doing. One of the scientists working on transcriptome profiling and immune modulation of VKC. And this is a 5-year study funded by DBT. And here we are trying to establish an animal model of VKC. And our overall goal is, can we treat VKC with mesenchymal stem cells or mesenchymal stem cell derived exosomes? And we don't have to use any systemic steroids or the immunomodulation. So what we are doing here is we are taking the VKC patients' tear samples and where possible impression cytology, and also culturing the conjunctival epithelial cells in the lab, and we are seeing what the tears contain. Can they create a disease in the lab in vitro? And we are able to find something interesting, that we believe that the fibroblasts are not very active in VKC, but here we are seeing the fibroblasts are quite active, and they are pre-primed for pro-inflammatory factors. This is like patient undergoing a AMG for shield ulcer, and we took small cones piece and sent it to the lab, and then trying to understand which are the pathways, how these mechanism works, and similar we are developing this model in the mice. So in summary, the most of the VKC patients are mild. You don't need systemic treatment. Moderate to severe, maybe about 1/3 of patients in my practice would need systemic immunomodulation, and 1/3 of these patients have some serious blinding potential, and about 3 to 5% patient may have LSCD. So my goal is to prevent these LSCD to be developed in these patients by using systemic immunomodulation. Thank you very much.
Thanks a lot for your excellent presentation.
Thank you, sir.
We'll open the floor for discussion.
I have just a comment regarding your study on the tertiary care center.
Yes.
Probably the complications are all exaggerated because it is a reversal.
Yes, true. Yes, absolutely.
Because vernal is usually a mild disease.
Yeah, that's why I'm saying that more than a very large percentage of patients are mild in general practice. Because we are a referral bias, we get more complicated cases.
And I have a comment also. I found that tacrolimus drops is very useful, and you can always increase the concentration from 0.01 to 0.03, and avoiding all systemic medications, since it is only locally confined to the ocular surface. And some of these overgrowth of the conjunctiva, especially the conjunctiva, and sometimes even the cornea, disappears with just topical
yes,
tacrolimus.
possible, absolutely
Except
possible.
some of the examples that you have showed with the diffuse fibrovascular adherent membrane over the cornea. And even some of these, you can even remove them surgically and then start tacrolimus, and you might get cure without any use of systemic.
Yes.
And I also noticed that you use frequently systemic oral steroids, which in our practice is very rare that we use.
No, I think
especially in this age group, which is usually children.
No, but we are seeing very different patients. See, it's not what you are seeing and what I am seeing are very different people. Meaning that patient who I get to see are very, very advanced disease. They've gone through this topical treatment, and most people don't use tacrolimus drops. So maybe you are making it. They are not available commercially. Tacrolimus ointment is available.
Yeah, but it is ointment is sometimes is not tolerable. But I found the drops once after the first week very well tolerated.
Yeah.
Preparations of the drops are extremely easy, especially with
we
the
will try. We will
drops.
try and make those and use.
Yeah, I mean, we used it. I mean, and we presented in Cornea when I was back in UK. We had 30 patients with VKC and AKC who were on systemic immunosuppression, either tacrolimus, steroids, or a combination. And we didn't have any tacrolimus drops, but we used the skin ointment. And we were able to stop systemic treatment in 30% of the cases. And since then, I think where tacrolimus is a game changer, I totally agree. In VKC, tacrolimus is a game changer. Whether it is drops, whether these are ointments, they work wonder in VKC.
Tacrolimus is extremely easily to be prepared by drops.
Yeah,
as I mentioned yesterday,
Please
you can have
say
one
it again.
capsule dissolved in 10 ml of Teas Natural, you will get 0.01%. And many of our colleagues in the private practice, they use it. And this hospital is still reluctant.
No, we are using it.
No, I know, I introduced it.
Yes.
But the problem, the limiting factor, I was discussing it yesterday with the pharmacy director. And because of lack of bottles, you don't have to have empty bottles. You can use Tears Natural 10 ml and get
Infection
that capsule
control.
dissolved.
The concern is the infection control if you put it in that bottle. Yeah.
It is still not available, and it is a problem for the patients.
Oh, we know that. No, I'm on your side rather than their
See,
side.
this infection control and all that hospital, they will have control. But outside, if you are practicing, you have to find solution to your
Actually,
problems.
this was mentioned by him. They have an issue with infection control committee, and I told him having patients denial from getting access from this is much more complicated.
Serious.
Having these patients develop a lot of complications with that, have this medication that is simply prepared. And this hospital is probably the best qualified to prepare these medications.
Yeah.
Yeah, regarding the tacrolimus, it is very important and it is very effective. Yet there are patients that even if you use tacrolimus and all the topical medications, you still get active disease, and then you need really to use systemic medications. And you were able to save 30% off. What about the other?
Which means
70%?
60-70% were still on systemic.
Still on systemic and need systemic. I think more important than or equally important is preventing the complications of VKC and screening the patients, the young patients, or the schools. And this needs a national program looking at the schools and picking up cases of VKC. This helps a lot actually in preventing the dire complications of aggressive vernal and the keratoconus, and it may reduce even the need for keratoblasties in the future. This should work together with treating the patients with established active disease and those looking at the patients or the young kids in schools. So yes, I think the systemic steroids and other immunosuppressive medications are still needed, even if tacrolimus is available. Having one thing that patients do not use medications regularly, and even in the hospital, the way the medications are applied to the eye, and we see this frequently when we are treating, for example, microbial keratitis. We prescribe, for example, 2 medications, and then they pour the medications within seconds on the eye. And the patients, I think, at home do something similar. So even if you prescribe 10 medications, patients will tend to put the medications without any interval, and then they are as if they are not using anything. And if the patient is tearing, then this reduces the effect of any topical medications, and you may need actually to start systemic medications until the tearing and the symptoms are much less. Then the topical medications may take some effect.
I agree.
Very true.
I have one question about allo transplants which you are doing. I mean, these are patients who have got a very active immune system. I mean, they're hyperactive. I mean, AKC, VKC, and then they are young. They also, again, they have got a hyperactive immune system. So what is the success rate of your AlloSlat or allo?
AlloSlat at VKC, I have not done a whole lot, maybe around 10. And I think the success rate is very good, because you are able to take care of the systemic disease by your immunosuppressant. And you're using 3 drugs. So for immunosuppressant, that may be overkill, but for limbal allo survival, that is required. So you have this patient, Abhishek Sharma, now more than 20-year follow-up. I have another patient that now 5-6 year follow-up. There are LVP patients which I am now not following, but were followed there. And now I've done 3 AlloSlat in VKC patients here after coming to Sarof.
Okay.
So I would say they are one of the very good outcomes.
Because I would be very reluctant doing an AlloSlat in a youngish patient who has got an hyperactive immune system.
I'm not very reluctant, because to me, because the child is whole life is getting affected. See, there's no other option for you to salvage their vision. So either they are doomed to be being blind whole life, or you take this calculated risk.
And I think you need to take the amblyopia in consideration. If you want to wait until the patient is older, then the patient will be deeply amblyopic because of the disease. So even if the cornea clears for some time until the patient passes the amblyopic age, and then the cornea becomes opacified, then the patient can wait until further rehabilitation. But amblyopia is an issue, actually.
Yes, absolutely. And after that, if you do all these procedures anyway, they are not of much help. Yes. So that window is very narrow.
And this is a lesson learned for me. I mean, I think we need to treat. Any further question? In that case, we conclude this session. Thank you all for coming. We're going to have a group photo of all the senior faculty people and the visiting consultants, and then we will conclude. Thanks a lot.
And thank you very much for the opportunity and wonderful hospitality. And thank you very much from the CMA department. Wonderful people. Thank you.